Hello, everyone. I'm Brandon Hawker, and welcome to today's Open Minds Market Intelligence team. And I'd like to welcome you to today's Circle Elite Executive Roundtable, Improving Quality and Strengthening the Bottom Line, the Advocates Case Study. Today's roundtable features Diane Gould, Danielle Dunn, Brenda Mealy Soares, Diana St. Cyr, and Elise Friedman, all from Advocates and Open Minds. Diane Gould is President and CEO of Advocates, a nonprofit human services agency that provides community-based services throughout Massachusetts. For more than 35 years, Diane has held clinical and leadership roles at Advocates and directed a broad range of clinical, residential, and support services that promote empowerment, inclusion, and health equity. Throughout her career, Diane has worked to build diverse, inclusive community coalitions that address mental health and social service needs. Diane holds a Master's of Social Work degree from Simmons College, and she earned her Bachelor of Arts degree from the University of Massachusetts with a concentration in English and Women's Studies. Danielle Dunn has a Master's degree in Counseling Psychology from Framingham State University. She is a licensed mental health counselor in the state of Massachusetts. Danielle has more than 15 years experience as a psychotherapist. Danielle has spent much of her career specializing in trauma services. Her experiences include community counseling, residential programs, and program leadership. She is currently the Vice President of Integrated Clinical Services at Advocates. Advocates provides a continuum of behavioral health services across the plan that she heads up. Brenda Mealy Soares is the Senior Vice President of Behavioral Health Services at Advocates. Brenda has worked in community mental health and substance use recovery agencies since 1985. She has been employed with Advocates since 1990, and she is currently overseeing the clinical and administrative operations of the behavioral health services. She oversees residential and outreach services for men and women funded by the Department of Mental Health, as well as services for deaf or hard of hearing individuals. She opened the first in Massachusetts deaf respite program. In addition, she also oversees federal housing programs, crisis stabilization programs, 2 social model substance use recovery programs, 4 outpatient clinics, a forensic mental health team that provides behavioral health services for inmates at the Worcester County Jail and House of Corrections, emergency service programs for 31 cities and towns, and integrated care management teams, as well as co-response jail diversion programs and jail and prison reentry services. Diana St. Cyr is the Senior Director of Revenue Cycle Management at Advocates. She has 32 years of experience within the revenue cycle and practice management industry, including experiences in the field of behavioral health, pediatric specialties, and primary care. Ms. St. Cyr is a certified medical coder since 2001 and skilled in effectively mitigating issues to drive practice efficiency. She empowers teamwork to produce effective solution-based results attributable to extensive medical leadership backgrounds and analytical skills. Prior to joining Advocates, Ms. St. Cyr worked at Massachusetts General Physicians Organization, overseeing billion operations for 26 practices. Most recently, she was the coding operations manager for primary care and behavioral health and was the project lead on a professional billings HCC project. Moderating today's roundtable will be Elise Friedman. Elise Friedman has over 20 years of healthcare marketing experience with expertise in accountable care, health information technology, value-based solutions, population health management, pharmacy benefit management, and managed care. She is currently the marketing lead for Otsuka's online nephrology community for healthcare professionals, where she is focusing on growing the community's HCP membership and optimizing member engagement through a range of strategic initiatives and platforms. Throughout her career, she has managed multiple product launches and developed client communications, marketing strategies and implementations, and webinar series promoting each organization's solutions and product portfolios. Prior to joining Open Minds, Ms. Friedman was a marketing consultant at Cigna, senior marketing lead at NextGen Healthcare, and a marketing manager for FutureScripts, a startup PBM and division of Independence Blue Cross in Philadelphia, where she managed the pharmacy RFP initiative in collaboration with IBC's RFP team. Ms. Friedman earned her MBA from the Florida Institute of Technology in Melbourne and her Bachelor of Arts degree in psychology from the University of Massachusetts, Amherst. Excuse me. Recognizing the need for specialized support services for people who have lost beloved pets, Ms. Friedman became a certified pet loss and bereavement counselor in 2018 and started a private referral-based counseling service called Paws and Hearts. Before we get started, a few housekeeping reminders. Your audio will be muted during today's briefing. However, we encourage you to submit any questions you may have using the question box located on the right of the screen. We will present audience questions at the end. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Elise, without further ado, I'll turn it over to you.
Thank you. Diana, can you get me the slides? Just need somebody to put the next slide. I'll give you the background. Thank you very much for the introductions, and thank you very much. So we know that I bet everybody's sick of hearing the word pandemic, but the pandemic has caused a lot of issues for everybody, particularly in the health and human services sector. So when we say these are unprecedented times, I said, well, let me look up the definition of unprecedented. And as you know, it means having no precedent, without instance, and never before known or experienced. I can safely say that the pandemic has been a never before known experience in our lifetime. COVID has impacted human services and behavioral health services and behavioral health providers, and I would call that a colossal double whammy. Next slide, please. Thank you. So 70% of Americans say that the pandemic has negatively affected their mental well-being. So when I say that the pandemic's colossal double whammy, it's been financially devastating for human service agencies over the past 2 years. And on top of that, the need for behavioral health treatment has escalated dramatically. The pandemic has put mental illness and addictive disorders in the national spotlight. Next slide, please. So for today's case study, Advocate's ingenuity in navigating tough waters. Advocate's executive team will share with us how they managed to align operations and finances across the organization, covering 4 outpatient mental health and substance use clinics serving 8,000 children, adults, and families every year. Last slide, please. Thank you. So let's talk about ingenuity in action. Advocate's turnaround project. Even pre-COVID, up until 2015, the clinics experienced significant losses, and the agency was evaluating the feasibility of maintaining all 4 clinics. Leadership then undertook a turnaround project with strategies to effect positive change, planning for long-term growth, and to ensure program fidelity, and evaluating data to refine service offerings. So I will now hand this off to Diane Gould, where she will talk about the strategies, the best practices, and the results that they had involving clinical operations, infrastructure, and revenue management. Take it away, Diane. Thank you.
Thank you, Elise. We're very happy to be here with everyone today. I'm going to give, my name's Diane Gould. I'm the president and CEO at Advocates. I'm going to give just an overview of Advocates services, and then the team will really talk about the turnaround project. So Advocates is a nonprofit human service agency. We were founded in 1975, and we are based in Massachusetts. Our mission statement, you can see here, Advocates partners with individuals and communities to shape creative solutions to even the greatest life challenges. Our motto is first we listen, and then together we partner with communities and people we support to do whatever it takes to help people thrive. We currently employ 1,600 staff, and we serve upwards of 30,000 people each year, people with a broad range of needs, and our programs are in central and eastern Massachusetts. Our services are organized into several service areas. We have behavioral health and peer support and developmental and brain injury services. We're going to be talking mostly about behavioral health today. Let me leave that for last. Our developmental and brain injury services include residential and day supports for people with intellectual and developmental disabilities and autism, as well as traumatic and acquired brain injuries. We also provide shared living and adult family care, family supports through 4 or 5 family support centers and clinical teams. We have a large and robust peer support team employing about 50 peer supports and recovery coaches, certified peer specialists, people who work in the area of self-advocacy in relation to people with IDD and autism. recovery coaches. We have the Living Room, which is a peer-run crisis alternative, and our peer support team provides fulfills human rights coordinator positions throughout the organization. And then focusing on behavioral health, our behavioral health services include outpatient clinics, which will be the focus of the presentation today, psychiatric emergency services for 31 cities and towns, a broad range of integrated care management supports. As Brenda's bio reflected, we provide a lot of supports to people who are deaf and hard of hearing, primarily by people who are deaf and hard of hearing themselves. We have residential services that are funded by the Department of Mental Health in Massachusetts, and also programs, residential programs for people with substance use disorders. We have a range of community justice services, including co-response jail diversion programs and reentry services, and a large number of children's behavioral health initiative programs for children and families. So Danielle will take the next slide to talk a little bit about our clinics.
Hello. These are 4 outpatient clinics that serve about 8,000 people a year. We provide individual, family, and group therapy and medication management for children and adults. As it was mentioned earlier, the clinics have struggled financially for years, despite the predecessor's efforts to achieve margin. Advocates made a strategic plan to invest in the clinics in order to meet the needs of the community and become financially viable. We did a lot of work as a team to really turn that around. Next slide. You can see here a 25% increase in contribution margin from fiscal year 17 to fiscal year 2021. We'll review the details of how we achieved these results, starting with updating operations and infrastructure, and then implementing new ways to manage clinical operations, increase quality oversight, use data to inform our decisions, and to manage billing and revenue. The goal at every step was to increase quality of services for the people that we support and to make Advocates a place where people want to be and want to work by supporting them with leadership and administrative oversight so that they can concentrate on clinical work, which is also the work that generates revenue. Next.
So let me tell you what was happening in the clinics when Danielle and I first started to take a look at what was going on and why we were consistently losing money. The prior, when you're losing money, the prior leadership took a look at their budgets, and anything that didn't have anything to do with billing or providing a service that we could bill for, they started to eliminate those positions. And what happened was the actual working of the clinic still needed to occur. So the people who were left were doing like the bulk of the work, and actually it pulled away from their ability to actually do billable time. So we ended up we sort of separated this piece out, and we thought we need to look at the clinical area, we need to look at operations, and we need to look at revenue separately. And what we started to see was that in the revenue section, the people who were doing the billing were also now running the front desk. They were managing the milieu. They were managing, all the details of running a clinic, and it was taking away their ability to actually do billing, and then actually recoup what was outstanding. So we started monthly meetings to sort of take a look at the, accounts receivable. And we realized that part of the problem was they did not have enough time in the day to do the job because they were distracted by all these other pieces. So one of the first things we did was to move the folks who were supposed to be doing billing completely out of the clinic altogether. We sent them over to our fiscal office, in our corporate office, so that they could spend all their time either billing or retrieving what insurance company were not paying us. And that takes a lot of dedication. And as soon as we did it, we saw an increase in our revenue, like without any other, not looking at anything about productivity at all. We just saw that change. So the other problem was that in moving those people out, we ended up having to look at the structure that we had left, which was not much. And so we decided that we needed to actually backfill and hire people who were just going to answer the phones, just going to manage the waiting rooms, do the scheduling, and we pushed the operations portion of running the clinic back to the clinic director, which at the time was Danielle. The next. So the next part was to look at what the clinical staff were doing, and it was exactly the same problem. Because of those people who were doing two roles, billing and the sort of structure of the clinic, a lot of the detail of running the clinic ended up falling to the actual therapists and medical staff. So they were doing all the chart audits, they were doing printing, faxing, anytime anybody asked for a release of information, they were having to do all this work, which again took away from their ability to actually see people and bill for those people. So we ended up I think the sort of overall was everybody was working as hard as they possibly could. We just didn't have them working to their right level of licensure or their standard. So we decided that we were going to actually have to spend more money by putting in the infrastructure, hiring secretaries, hiring enough supervisors, hiring the administrative staff that we needed. We also included adding 2 medical assistants for the medical staff. And these folks really focused in on, we get hundreds of refill requests every single day. So they would do all the research that was needed to find out, did the person really need the refill? Why did they need a refill? Did they miss their appointment? And they could actually spend some good amount of time with the actual person who's calling looking for the service to figure out why they needed it. And that relieved the medical staff from doing any of that, all those phone calls and all the work. Medical assistants always also handled all the information that was needed from the pharmacies. And then on top of the last thing that we hired was a documentation specialist, because that person really helped the clinical staff stay on top of the notes so that we could bill, and also the treatment plans. So next slide. I think this is going to go back to Danielle.
Right. So I'm going to talk a little bit more about how we did this. So, we really looked at, an ongoing analysis. We determined, as Brenda said, that we need to invest in infrastructure. We brought in the people as she went through who are skilled at particular tasks to allow them to focus solely on those tasks, to really specialize in what they do. And it freed up the time for clinicians to focus on clinical work. At the same time, we really looked to modernize our systems. We shifted from paper chats to electronic health records. We hired the administrative staff and intake coordinators to alleviate the clinicians, as Brenda talked about, the time spending doing all of that non-clinical work. We hired the site directors to implement consistent systems. So some of the systems that we put in place that the directors closely monitored was caseload, so we can continuously monitor continuity of care and medical necessity, which lends to access for the community. We ensured qualified staff were assigned cases per payer guidelines, and that they met the needs of the member. We made sure notes were completed within 24 hours to ensure timely billing. We took over the scheduling for the medical team, as well as clinicians who were new to the clinic as they built up their caseloads. We monitored productivity with weekly reports and systems to oversee no-shows and increase engagement. We monitored documentation to ensure that we had thorough charts that documented all the clinical work we were doing. As a result, we have had great external audits. We implemented automated appointment reminders, which has really helped with people coming into the clinic and coming to their appointments. And then lastly, as did everybody else, we implemented telehealth throughout the pandemic, although we had happened to start it prior to the pandemic as a pilot, but we were able to quickly pivot and have had really good results from this. I think it has helped with the continuity of care. Barriers to treatment before, such as like car problems or daycare or health issues that were preventing people from making their appointments, are able to now have access to the services they need through telehealth. All of this has allowed our site directors to have real-time information on the status of operations. Our leadership team has been able to analyze these trends and continue to make changes for success. In order to do this, we really looked at the collaboration throughout Advocates and how all of our departments could work together. We worked with IT to implement the electronic health records and to incorporate succinct documentation. We worked with quality management to ensure members are receiving the best care possible. We worked with the fiscal team to implement practices, systems, and technology to increase billing, reduce billing turnaround time, and reduce human error, and as well as data analytics to help us understand the trends and continue to move in the right direction. We initially, when we began this project, we worked with our 2 larger clinics, and after we had those clinics working well, we then applied the same model to our smaller clinics in Harvard and Waltham, and they were able to really get up to speed quickly and had great results. Next slide. Here you can see the outcomes of one of the changes we implemented with decreases in the no-show percentage for both our clinical staff and our medical team. So the blue bars show the no-show rates for our therapy appointments, and the orange bars show the no-show rates for, and the blue bars in 2017, and the orange bars show the no-show rates for 2022. We have we have forms for the clinical staff as well as the medical team. You can see on the left that the 2017 no-show rate for 2017 was 11%, and it went to, in 2022, we decreased it to 7%, so it was a 4% decrease. So clinically, that shows us that our members are engaged. And then financially, if we're looking at that with the 4% change, it values $158,000 in revenue due to the increase of members showing up for appointments. No-show calculations vary by each site and each type of service, but the national average shows that it's about 18%. So what we're doing is keeping us below average and providing more services to people. Next slide.
Thank you. So for some changes in the revenue cycle management team, we had some technology changes utilizing electronic claim submission. We went from a submission of once a month to 3 times a week, allowing us to have a quicker turnaround time for claim processing and for payment. We also implemented about 90% of our claim submissions electronically, reducing paper. Minimal paper is used now. It might be for a smaller commercial plan or for an appeal, and those are probably just a few times a month rather. The edit system we put in place for the electronic transmissions allows us to scrub the claim before it's sent out. So now we're able to send a clean claim out, again, reducing the denials from the payers. We also implemented an online payment portal before we were using the POS machines. And since we implemented that in about November of 2020, we've seen an increase in collecting copays and patient balances. We've implemented this through the billing office and all the clinics. It proved to be beneficial, especially during COVID, where there was no in-person visits, there was no clinic staff, that they were able to accept the payment either via the Zoom online or via telephone by calling, and we could apply those payments. Another thing that we had implemented was to make sure that all of our payments coming in were EFT or direct deposit. We reduced the amount of paper checks we were receiving. Again, it reduces the amount of paper and also the time that the staff have to create the deposits and actually go to the bank, allowing me more time in the office to do the work with the billing. The other implementation that we incorporated was our client statements. They were printed and hand folded and mailed by staff, which could take up to a couple days. We implemented a machine that actually will fold stuff and seal the envelopes, reducing it from 2 days to about 4 hours a month. Again, allowing us to focus on what is more important. For billing correctly, the clinicians are now billing for the services. Before all the billing was submitted to the billing team, it could take a few days to a week to actually receive that, for it to be entered, and then for it to be posted and mailed. So now it's actually done within, I think, less than 2 business days. The charges are in. It goes directly into the billing system for the billing team to review. Again, we have claim edit in process to catch these. If there is a license level issue, a coding issue, missing information from a note, we're able to catch that up front and actually correct it again and send it out. Our AR timeline, our team works our accounts receivable daily. Excuse me. We can track prior work that was done, follow up, put ticklers on claims, find trends or issues that we're having with certain payers. And by doing this daily, we're able to catch a lot of issues that may have happened and reduce the outstanding AR. We've also had some smaller projects with payer-based that from the trends that we have found, we've been able to make sure that the claims are processing according to the contract and to the correct rates. And then for the collaboration, we work very well and very close with all the clinic staff, the directors, the clinicians, and in regards to working on billing issues, like I said, guidelines and workflows, we put policy and procedures in place for different various things, collecting eligibility, authorizations, and co-pays. The eligibility coordinator is able to monitor multiple clinics. We are checking insurance verification 24 hours prior to a visit, so we're able to make changes to insurance, make sure we're billing the correct insurance, and it actually has decreased our denials and increased our revenue. As for the clinic growth, again, as I stated before, you can see by all the work and collaboration we've done with the clinics, the directors, again, the clinicians, we've been able to reduce our bad debt, increase our revenue. The workflow has just been a big help for revenue cycle and for the clinics.
So this slide shows our child behavioral health initiative, how we've increased the revenue and infrastructure there. So CBHI services are home and community-based behavioral health services available to Mass Health enrolled children and youth under the age of 21. Advocates provides in-home therapy, in-home behavioral services, and therapeutic mentoring. We took the model that we applied from the clinics and we used it for our CBHI services program, and it was also successful there. You can see how we've had the growth and revenue by using the same method. Next slide.
Well, this is where we ask for questions from the audience, any of the attendees. Okay, we have a question here. Somebody wants to know, what EHR system are you using now, and is that system also generating billing?
Yes, we use Peter Chang Enterprises, PCE, and it does have a billing system, although Diana could probably speak to that much better than I can. So.
Yeah, so it's Peter Chang Enterprises, ACES. Once the information is entered by the clinician into the EHR, it creates the billing for them, and it comes directly to us.
Great. Did staffing cover all the clinics or only one?
I can speak to that. We have some of the staffing is specific to clinics, like a site director and admin at each, but we do have a centralized intake team to make it easier for people seeking services. And then we have separate clinical staff at each of our sites.
Great. If anybody has any other questions, you can just type them right there in the chat panel or the question panel, and we will take them. One question we have is you implemented quite a few changes, and obviously they paid off. And this was not an easy task. Can you describe some of the reactions you had from staff in terms of what people typically do not resist change, and you made some fairly dramatic changes? How do you feel staff reacted, or did you encounter a lot of resistance to those changes that you were trying to make?
I actually think most of the changes we were making, everybody was just so happy to get help because we were adding help, we were adding infrastructure. So mostly the staff reacted very positively to the changes. I think the place where people really resisted was when we moved that billing operations team out of the clinic. People had relied on them for everything from, there's no water in the bathroom to, help manage the waiting room. And so it was hard for them to lose that group. And it was also hard for that group to leave. They were very connected to the clinic for many, many years. And it was a big culture shift to like get themselves out of there and move over to our fiscal department. So I think that was really hard, but they also knew that they needed to be able to focus, and it was very hard for them to focus where they were. So I'd say that was one of the biggest resistance. I don't know, Danielle, if you can think of another place where there was more resistance, or other resistance.
No, really, I think the staff for the most part were happy. They didn't want to have to fax things. They didn't want to have to do all that paper documentation. So when we took that off their plates, they were so happy. And even like, I think moving to electronic health records, I think it was, that was a little bit challenging for some staff, but for others it was easier. I think overall it's been a success and people like it. But I think at first just learning the systems was a little bit harder, but people are happy.
Sounds great.
And Elise, if I could just add
Yes,
one thing
sure.
about a little piece of history. I remember before this leadership was in place at the clinic, meeting with the clinic staff at a time when there was just a very heavy emphasis on productivity, and the staff saying to me and to us, you're kind of on us about productivity, but you're requiring us to do all these other things that take away from our ability to achieve the productivity expectations, like faxing, like making phone calls, like all of the things that that the team added infrastructure for. And so I just say that in support of the response that this was a welcome change. People had really been asking for it and complaining that they didn't have room to achieve the productivity expectations because there was so much administrative work that we were expecting them to do that the infrastructure really addressed. May I ask a question, Elise?
Yes.
Yeah. So I had a question about the centralized scheduling. I should know this, but was there reluctance or concern on the part of the medical team in relation to centralized scheduling? Because you imposed that for the prescribers as well, yes?
Yes. So yeah, actually, initially it was a little bit hard for them to give over their schedules because I think they wanted to make sure they were in control. They knew they could fit in members who were in need of services when the time came. But I think after we did it for a while and they realized how useful it was, that now they really like it. So
yeah, thank you.
You gain their trust for their precious time. So you've had some tremendous growth and some tremendous successes. So can you talk a little bit about some of the things you're doing to continue and keep this momentum going? Because it was a big overhaul and a big project, but as we all know, nothing's ever quite over. We have to keep the momentum going. Can you talk a little bit about some of the strategies you're implementing today that keep up that focus and positive change?
I think one of the things that sort of perhaps is like the theme is that when things are not going well at the clinic for whatever reason, we try to figure out how it's not really about the person, that staff person who's not writing their notes, let's say. It's not about that person. It's like, it's just, we need to figure out how to make it happen, and so that it's easier. So we struggled with some of the medical staff. Actually, I mean, they were seeing people all day long, and then they were spending hours at night writing their own notes. And it seemed like, wow, what a burden. And so we added scribes, you know, and at first we decided, well, we couldn't really afford them. So we wrote grants and things like that. But after a year or so, we realized we don't even need to do that because their productivity is so much better again. And so it handles itself. So I think that's really the way we try to think about it, is like, there's got to be a fix. Running a clinic or running clinics is very, very complicated with third-party billing and all the different factors that, you know, licensing and all the things you have to attend to. And so it gets quite complicated for, you know, everybody from the person who's answering the phone to the clinic director. So.
Great. We've talked a lot about the staff reaction and your employees' reactions. Can you comment about any positive changes that you noticed in your clientele, the patients that you treat? Did they notice things saying, you know, wow, we don't have as many wait times, or anything come to mind in terms of reactions you could gauge from those that you serve?
I think the biggest piece is access to services. So we've been able to really, by monitoring a lot of things, making sure when people need services that they can come into the clinic and get what they need. So I think it's been a success. Another thing too, I guess, thinking back to, is once we were able to turn around the clinics financially, then we were able to, you know, fix up the clinics, right? We did over our waiting rooms. We really looked at all the therapy rooms and, you know, did new carpets, paints, got new furniture. So like it was a more welcoming environment, and we were in a place that we could do that. So I think that alone made the clinicians feel valued and the people coming in for services as well.
Actually, the first year that we made money and didn't lose money, we threw a party at the end of the year. And we invited everybody to celebrate, which I mean, it was more of a token, but boy, people really appreciated it. Really.
It's fabulous. So in retrospect now, the project is several years in the making. Is there anything that you would have done differently, knowing what you know now, in terms of how you approached your strategy?
We spent a lot of time in meetings talking to the staff, but I think that might have been the place where we could have, if there were any hiccups, the staff size is large, and we probably should have done more in terms of, you know, written communication on a regular basis. This is changing. Remember, we talked about it yesterday. I'd say that was an area that probably we could have done a better job.
And so we know that, you know, in health and human services and in this field, there is a tendency to burn out, for clinicians to burn out. Would you say that with these changes, you saw sort of a decrease in that sense of burnout amongst your staff, your clinical staff?
Initially, we did. I think, you know, putting all these practices in place, we had our retention was so good. I think then when the pandemic hit, I think some things changes and people started to like rethink career paths. So at that point, it's been a little bit different. But as far as like when we initially did all this, people were happy, and it certainly impacted retention.
That's great.
And we were actually able to make significant increases in people's pay as a result. So that really made a difference. Last year, people really got quite large increases, and it was because we're able to now, like, we can make money, and they certainly deserve it.
Yes. So you started the initiative actually before the pandemic actually hit. Is that correct? I mean, you started this whole process. So then you got hit with the pandemic. How did that, you know, you probably had to pivot very quickly. What did you do in terms of, you know, how did you go about like implementing telehealth? Maybe you hadn't had that quite as operational prior to the pandemic. Do you want to speak to that a little bit?
Yeah, I can speak to it. So we did have prior to the pandemic, we had started a pilot to do telehealth. So we had put in place all the policies and procedures to implement it and started working with one of our group homes to provide medication management through telehealth. So we were actually in a good place that we had the systems for it. So then when the pandemic hit, we quickly pivoted and we went to virtual services in probably 24 hours. So I think we certainly had to make sure that people had equipment at home, but at least we had some systems in place to make sure that we could have it happen. And we were able to continue to provide services to the people in our community, which was what was most important.
So now that some people, you've adopted somewhat of a hybrid model, would you say? Where some people are still doing. So what would you say your percentages are? I don't know if you mentioned that in your presentation, like what percentage of your patients are telehealth and what percentage are in person?
We probably have about 70% that are still doing telehealth. So I think with the rates of COVID, and I think we keep getting spikes in Massachusetts, and that people get a little bit wary and want to stay home, but we do have, all of our clinics are open. We offer same-day access. People can certainly come in, and it's really the member's choice if they prefer to have telehealth or have it in person.
Excellent. So are there any last pearls you would like to share with our audience in terms of if you had one piece of advice for how they can implement some best practices in their operations, what would you want to share? Or I know it's hard to pick one, but if there's anything that you could leave them with.
I could speak to that. I think that having leadership on board with making these changes, because a lot of times when you first implement things, it's going to cost you money up front, right? When able to, put in these positions and without investing into it and really being committed to it and having the leadership say that that's okay, then I don't think we would have been able to make those changes. So I think to really work as a team and to be able to move forward.
Excellent. Well, this has been a wonderful session, and I've learned a lot, and I think that we have somebody else, I'm sorry. So it says, what is your ratio of in-person telehealth visits currently? Then you covered that. So you showed a lot of growth in people showing up to appointments, but some of that awesome improvement might be due to more availability and ease to make telehealth available. So let me see. There's any other questions. So, well, this has been great, and we do have the slides are available for our attendees, and I think Brandon's going to take it away and close us out.
Yes, thank you, Elise, and thank you everyone from Advocates. Thank you all in the audience for joining us for today's web forum. I just want to remind everyone that the slides and recording will be available by tomorrow on the Open Minds website. Also, the full Circle Elite Executive Roundtable series is available on demand as part of the extensive Open Minds library and can also be found on the brand new Open Minds YouTube channel as well. Also, please join us for our next roundtable on Thursday, August 18th, beginning at 1 p.m. Eastern Time. The topic will be how California health plans will change their contracting models and network management under CalAIM. In this roundtable, Rafael Gonzalez Amazuca of Aetna Better Health of California and Bo Hanneman, Regional Vice President of Local Engagement and Plan Performance at Anthem Blue Cross, will discuss the process and experience of California managed care plans and their engagement of provider organizations in the creation of these new services. This will be the third in a special quarterly series from the Open Minds that features California case studies focused on strategy, health plan contracting, financial assessments, market services, and CalAIM preparedness regarding program readiness, implementation, and technology. For a full list of upcoming roundtables or to register for the August 18th event, please visit the Executive Roundtable page under the Events tab at openminds.com. Thank you all so much.
Thank you.